Hi, this is Cherry, and I'm here just to spend a few minutes and talk to you about how to actually do well on a quiz or exam based on test-taking techniques, which kind of is a make it or break it technique that we see students struggle with from time to time. Sometimes we have students that it's obvious that they know the content, but their quiz and exam scores don't reflect what they know. And frequently what we find is that the students just don't really take tests well. And I want to just give you some tips real quick on how to improve that. Okay, so hopefully this won't take too long. One of the issues that we see with test taking, especially when you get to the National Registry exam, is that they use medical terminology in most of their questions, and they expect you to understand medical terminology, which stands to reason because that's the language that clinicians and medical providers speak. So if you run across a question, so let's look at this question quickly, and I'm going to highlight this just so we can see that. Okay, so a young female presents with costal, so this is a word that you may not know, costovertebral angle tenderness. Okay. She is conscious and alert with stable vital signs. Which of the following organs is most likely causing her pain? Well, the problem is if I don't know what that word means, first of all, it kind of throws me off kilter, and now I'm starting to doubt everything about myself. So don't do that. Just back up, take a breath, and say, okay, let me dissect this and figure out what it is. Very, very frequently there are clues to these big medical terms that will tell you at least partially what they mean. So let's diagnose this, because this is not a term that you've probably seen before. So part of this word, this is something that I recognize here, is vertebrae. I know that's the spine. So I know this has something to do with the spine. Now this word right here, costo or cost, I have seen that when we talked about the ribs. We talk about intercostal muscle use, the muscles in between the ribs. And so costo, or that cost, very likely is the ribs. So I've got a word here that's talking about ribs and spine, and it talks about ribs. So costal vertebral angle tenderness. Now, initially my response to this question might be, if it's talking about the ribs and the spine, this has to do with that spinal column or with the skeletal structure. But if you look at the options that we have, it's asking us which of the following organs is most likely causing her pain. So it's not the skeletal structure, is not the answer here. So what I want to know is, where is that costal vertebral angle? What is that? So I want to think about, where do the ribs meet the spine? Okay, and that happens in the back. Okay, our ribs in the front don't connect with the spine. That happens in our posterior side. So if I look at where those angles are, or where those ribs get together, maybe it will give me a clue. So if I look, here's the ribs coming up. I don't know if you can see this. I don't have a very good pointer. And here's the spine. Okay, and in here is that angle. Okay, now I want to look at what sits in that angle, and right there is my kidneys. So if I go back to the question, kidney is an answer, but let's make sure that's the best answer. Okay, is my liver in that angle? Okay. And the answer to that is my liver sits more in the front. Okay. And so it's in the front side over here. Okay. It's more kind of up in here. The other option that we have was the pancreas. Now the pancreas sits behind our stomach, so it's also up higher. Okay, and then the gallbladder is down lower. So what actually sits right here in this angle is the kidneys. More so, the kidneys sit in the back. They sit they're attached to our what we call retroperitoneal area. This area right down here, which is in the back. It's behind our abdomen, and the kidneys are attached there. So they sit very close to these ribs and spine, right there, tucked into that angle. So if I look at my options over here, liver, kidney, pancreas, gallbladder, kidney is the best option. Even though when I started through this question, I had no idea what that meant. Now, it might be a guess on my part sometimes, but I'm telling you, an educated guess is better than just picking an answer and moving on. So when you get to a medical terminology word that looks a little bit, what I want to say, intimidating, break it down. All medical terminology is broken down into small parts, and very likely you have heard some of those words during class or in your reading. And if you just take a minute, break it apart, and start looking for things that look familiar, you'll do much better on your test taking. Okay? So let's look at a question, because reading the question is frequently where we stumble up. Okay, so let's read this question. Let's not worry about the answers yet. A 62-year-old male patient presents with crushing chest pain, which he describes as being the same kind of pain that he felt with a previous heart attack. He has nitroglycerin prescribed to him, but he states he hasn't taken any. After completing the primary assessment and finding no life threats with his ABCs, what should you do? Okay. So let's do this. Let's not look at the answer. Let's look for abnormalities here. Okay. So we have a 62-year-old male. That's significant. I mean, that tells us something about our patient. Okay. And he's got crushing chest pain. That's definitely an abnormality, which he describes as being the same time pain he felt with a previous heart attack. So that previous heart attack is an abnormality, and it's definitely significant. Okay, he's got nitro prescribed, but he hasn't taken any. So let's identify he's got a nitro prescription. Okay. All right. So no life threats. That's normal. That's what we like to see. So let's look at this. Okay. Now let's look at our options and see if they mesh with that. Well, let's just look at this. I've got a 62-year-old male patient. He's got a history of a heart attack. He has nitro prescribed to him, so we know he has cardiac condition that continues on. He hasn't taken any nitro. No life threats with his ABCs, but he is experiencing that crushing chest pain. Okay. So what would I like to do with him? Before I look at my answers, what do I need to do? I've looked at my ABCs, so his airway is patent, his breathing is fine, his circulation is good. Okay. I'm not seeing signs of shock. That's in my circulation part of the ABCs. So, A, begin immediate transport and request a rendezvous with a paramedic unit. That's not wrong. I mean, we do need to get this guy going. I don't want to stay on scene very long with him, and having a paramedic rendezvous with me would be a good idea. So that's a possibility. I'm not going to jump on it. I'm going to see what my other options are. To contact a medical control. He's got nitroglycerin. That definitely may help him in the situation he's in, and I do need to contact medical control to give that. So contacting, that's also a good option. So that one is viable. Okay. Take a set of baseline vitals. That needs to be done. Okay. And then D is administer nitro unless he's taken any erectile dysfunction medications in the last 72 hours. Okay, so a couple of these are dealing with the nitro. And I would agree that nitro is going to be a good treatment for him if it's not going to harm him. So immediate transport and meeting with the paramedic union, we're not treating him. So although that's an option, I don't know that that's the best option because he's got nitroglycerin right there. We could give that and potentially alleviate some of that chest pain, open up the arteries, and get more blood flow to that part of the cardiac muscle that's in trouble. So contacting medical control to give nitro is good. We are going to have to do that. But what is medical control going to ask us? The first question they're going to ask you is, what's his blood pressure? So if I don't have that, I probably should not be contacting medical control yet. Okay, I want to have all the information they need. So maybe taking a set of baseline vitals is my best option. Okay, let's look at D. Administer nitro unless he's taken erectile dysfunction meds. That's good, but again, we don't know what his blood pressure is. So it would be harmful to administer nitroglycerin if his blood pressure is not adequate. Therefore, looking at all of these options, C, taking a set of baseline vitals, is my best answer. Okay? So you need to take some time and dissect this out and say, okay, this is right, but is there a better answer? Instead of, and this is what I see some students do, they read, let's say they read A, begin immediate transport and request ALS. Well, bingo, yeah, that's right. And so they select that without looking at their other options and making sure there's not an option that is better. Does that make sense? Okay. So reading the question, let's go through another one. You receive a call to a local daycare for an unconscious 8-month-old infant. Upon arrival, you determine that the infant is not breathing. That's a problem. Okay? So you should. Now, let's think about this. If I walk up there, I've got an 8-year-old and he is not breathing, what is the very first thing I need to do? What do I need to know most? Okay, so A, assess for the presence of a carotid pulse for 5 to 10 seconds. B, begin chest compressions and request backup. C, transport immediately. And D, assess for a brachial pulse. Okay, so let's look at this. We have an unconscious 8-month-old, okay, who is not breathing. Oops. I'm not very good with this thing here. Okay, not breathing. Okay, so let's look at this. On my AHA guidelines, if he's not breathing, the first thing I want to do is look at, does he have a pulse? I want to know, do I need to start CPR? Okay? So checking for a carotid pulse 5 to 10 seconds would be correct, except this is an 8-month-old infant. Where do we check a pulse on an infant? We don't check carotid pulses. So A, although checking a pulse is right, A is wrong, because carotid is not the right location. Okay? B, begin chest compressions and request backup. Okay. How do we know he needs chest compressions? He's not breathing. We have not yet checked a pulse. So although he may need chest compressions, we don't know that yet. So I'm going to say B is also wrong. Okay. C, transport immediately. I'm telling you, if I've got an 8-month-old that's not breathing, I'm going to want to get scooting pretty quickly. But I've got some things I have to do first. Okay. Transport is not always the best option at that very second. So let's look at D. Assess for a brachial pulse. Okay. Brachial pulse is the correct location. So out of all of these, D is going to be my best option. Okay. Could have been, some of those could have been right. I could have made some of this been right if I'd have added more to the question. So if you're asking, if you're telling yourselves, well, but if, so if you're adding but if, or if this is the case, or if this is happening, you're going to get that question wrong. Look at the question, read only what it's asking, and ask yourself, what is this question asking of me? Then look at your options and pick the best one. Okay. So answering a scenario-based question, most of the time these are based on assessment. Okay. So do what you would do in real life. Look for life threats first. Okay. Notice all the abnormalities in the scenario, and then treat your life threats as a priority based off of what your protocols would be. Okay. So my protocol wouldn't say transport and check for a pulse en route. My protocols would say immediately check for a pulse. So I want to make sure my priorities are right. If the assessment's already been performed in the scenario, then we can usually assume that pre-arrival stuff, I've got my PPE on, is the scene safe, number of patients, what's going on, is it a mechanism of injury or nature of illness, how many patients do I have, do I need ALS, all of that, most of the time we can assume was done before we got there. Now we're at the point that we're assessing the patient, and we'll go from that point on. Okay, I've seen a lot of students be like, well, this is going on, but I need to consider C-spine. Well, if you've got a medical patient or a trauma patient that's been assessed already, then we're going from that point forward. Okay, and then follow the AHA guidelines for CPR. You know what those are. You know how to do CPR. You know what order to do those in. So continue that when you are taking a test or a quiz. Okay. One more. You arrive on scene of a motor vehicle versus pedestrian accident. The patient, a 13-year-old male, is unconscious and has multiple injuries. As you're treating him, law enforcement advises you that the child's parents will be at the scene in approximately 15 minutes. What should you do? Okay, this is an interesting dilemma that you absolutely may find yourself in someday. So, transport the child immediately and have the parents meet you at the hospital. Possibly. Treat the child on scene and wait for the parents to arrive and give consent to transport. Begin transport. Number C, begin transport at once. Have the parents meet you en route to the hospital. And D, withhold treatment until the parents arrive and give you consent to treat. Okay, so let's look what we have here. We have a motor vehicle versus pedestrian. We have a 13-year-old who is unconscious with multiple injuries. So as we are treating him, law enforcement shows up. Okay, so as we're treating him, that means we have begun treatment based on implied consent. He's 13-year-old. Even if he were conscious, he couldn't give us permission. But being the fact that he is unconscious and he is 13 years old, we can assume that if the parents were there or if the patient could and would, they would both give us permission to treat. Okay? So if I started treatment, can I now down here in number D withhold treatment until the parents arrive? Or is that patient abandonment? Remember, our goal is to do no harm. So let's look at what our best answer is. Transport the child immediately, have the parents meet us at the hospital. Absolutely, with a child like this, unconscious with multiple injuries, he needs to be transported immediately. Okay. So that is a good option. B, treat the child on scene and then wait for the parents to arrive. Okay, if he's unconscious, something's wrong with his brain. He's got multiple injuries, and very frequently with trauma injuries such as this, we've got a patient that's bleeding out inside. Do we have time to wait on scene for 15 minutes for the parents to get here? Or is that causing harm? I'm going to say it's going to cause harm. Okay. So C, begin transport at once and have the parents meet you en route to the hospital. My question is, how am I going to meet them en route? I don't know where they're coming from. They don't know where I am. And this is going to take a lot more time than my patient might have. So I'm going to say that is not the best answer. And we've talked about D, withholding treatment is not a good option. So the correct answer to this one, based off of trial and elimination, the best answer is A, transport this patient immediately, have the parents meet you at the hospital. Okay. We'll do a couple more here. You and your partner are caring for a critically injured patient. Okay, so let's identify that as something abnormal. Your partner's controlling bleeding from the patient's lower extremities. So we've got some hemorrhaging going on. Okay. As you attempt to ventilate the patient using a BVM. All right, the fact that we're even using a BVM is significant. Okay. After repositioning the mask several times, you're unable to effectively ventilate the patient. Unable to effectively ventilate is significant. Okay, so I'm at the primary assessment part. Okay, we've identified there's a circulation issue. My partner's taking care of that. I've recognized that my patient is either not breathing or not breathing adequately because I've opted to go to a BVM to ventilate for positive pressure ventilation. So I've repositioned the mask several times and I'm unable to ventilate this patient. So let's look here. Begin ventilating using mouth to mask technique. That's not wrong. My question is why? What is that going to benefit the patient? Or is that going to help me be a better provider? And I don't know that there's any benefit to changing to the mouth to mask. So let's look at B. Hyperextend the patient's head and neck to reattempt ventilations. So think back in your textbook and in your scenarios in class and from the information you know, have you ever heard of us talking about hyperextending a patient's head and neck in a critically injured patient? My patient is hurt. So I should be using the jaw thrust technique so that I'm not moving that spine. So I think hyperextending the patient's head and neck right here could potentially be harmful. Okay. So I'm gonna keep going. C. Continue attempted ventilations and transport immediately. With the transport immediately, I think is correct. Continue attempted ventilations. Maybe. Let's see if there's anything better. So D is suction his airway for 30 seconds and reattempt ventilations. Okay. So suction, depending on what's going on with my airway, suction might be a good option, but is 30 seconds correct? Have we ever talked about suctioning a patient for 30 seconds? The answer to that is no. So because it says 30 seconds, D is wrong. So D is wrong. We know that B is wrong because we don't hyperextend a trauma patient's neck. A maybe isn't wrong, but I don't know that it's right either. So looking at all of my options, C, attempted ventilations and continue attempted ventilations and transport immediately, I think is my best option. I've recognized that I don't want to stay on scene. There's a problem with his airway that's more than I can handle, so let's do what we can do and let's get moving. So in this situation, C is your best answer, and it's the correct answer. And the last one, let's look at this. A 78-year-old female, okay, so let's just go there because that may be of concern, presents with an acute change in behavior. Okay, so change in behavior, and it's acute. That means what? That means that this is kind of a sudden thing. It hasn't been, chronic means it's been there a long time. Acute means it's sudden. So that's significant. This tells you his mother has a history of type 2 diabetes. Okay, we know type 2 is oftentimes not insulin dependent and can be controlled with diet. And she was diagnosed with Alzheimer's disease. Okay, so Alzheimer's is definitely going to affect her behavior, and diabetes will too. So she is diabetic, was diagnosed with Alzheimer's 6 months ago. Her speech is slurred, and she's not alert to her surroundings. Okay, so I have to look at this. What do I know? Okay, I know she had this sudden change in behavior. Her son is there. He tells you she's diabetic, she has Alzheimer's. Both of those can cause a change in behavior. Diabetes can cause a change in behavior fairly suddenly. Alzheimer's, not so much. I mean, the Alzheimer's disease is going to progress slowly. She may have periods where she's more alert and aware of her surroundings, and then periods where she's not. She'll probably bounce back and forth, but that's going to be her normal now. So I would think that the son probably wouldn't call if it was the Alzheimer's, because he would have seen that before, so that wouldn't make him call 911. Her speech is slurred. Alzheimer's would not cause that. That's a memory disease, and she will not be able to remember things, but it doesn't cause slurred speech. However, diabetes might, and some other things that might cause slurred speech. We need to keep that in the back of our head. A stroke may cause slurred speech. So let's see what our options are here now that we've looked at those abnormalities. Transport her to the closest psychiatric facility. Last I checked, we didn't do that. Last I checked, we got our patients checked out medically, and we let the physician refer them to a psychiatric facility. So I'm going to go on this. I'm going to say that's incorrect. Okay? Excuse me, I got the hiccups. B, inquire about the possibility of head trauma. She's 78 years old. she's diabetic, she has Alzheimer's. Is there a chance that she has maybe fallen and hurt her head? I would say there's definitely a chance. And is that part of our assessment? C, conclude that the patient's blood sugar is high. It absolutely could be with diabetes, but does that make an acute change? Generally, high blood sugar, we see changes in that patient over a period of time. Low blood sugar is what we see that comes on rather quickly and changes their behavior suddenly. Okay. So C, I'm not in love with that answer because I don't think it's reflecting what's happening in this scenario. Okay. And should we conclude that a blood sugar is high simply based on behavior, or are there other signs we would look for, like maybe rapid deep respirations, fruity smell to the breath? What was her behavior like leading up to this? How did she feel earlier today? How did she feel yesterday? How has she been eating? Has she been taking her diabetic medications? Lots of questions we need to ask there before we jump to the conclusion that her blood sugar is high. Okay? And then D, allow the patient to refuse transport if she wishes. She's not competent, so she is not capable of signing a refusal. So D is not a good option. Okay, A is not a good option. So we're down to B and C. Inquire about the possibility of head trauma or conclude that her blood sugar is high. Both of those are possibilities, but by far B is the best possibility. So that would be my answer for this question. Even though there's lots of moving parts and a lot of things we don't know, by the process of elimination, I can come up with the best answer. I just can't hurry through this. I've got to think through and talk myself through each one. So I hope this helps just a little bit. We'll probably try and do a couple more of these as we move through the course to give you some tools to use to make your test taking reflect truly what you know and not just what kind of a test taker you are. Have a great day, guys. Take care.